In 1986, we started to think about information tools that would help patients take care of themselves. We had a series of projects that we built where we were creating web-based resources. This was pre-web, but they were web-type resources for people to self-monitor, to interact with others, to get advice from clinicians. I was, at the time, working with a small group of people who were really interested in the clinical problems that couldn't be solved with traditional healthcare services. People with AIDS, caregivers of persons with Alzheimer's disease. So that as our work grew, what we were addressing and what we were trying to attend to is people are living at home. They don't know what to do all the time. They're not always clear who to call about that. So if we could use an information technology resource that would provide that. We began in the 90s to build web-based resources, web spaces, web pages that would tell people viscerally what to expect after a surgery or when you're caring for someone with Alzheimer's disease, and then how to manage those things, whether they're feelings of anger or shame, the experience of an older person who still has intimate feelings towards their partner who's now demented. What do they do with those feelings? How do they handle them? There's very few places that they can be discussed. So we wanted to build on the support that people had for each other, so we used a lot of the conversation, chat group, emailing, whatever technologies were available. That was predated any ideas, though, that patients would actually be considered reasonable information partners. And yet what was coming up in the 90s, an attention to patient-centered care, a realization of the amount of work that patients had to do to take care of themselves, started the whole consumer health informatics movement towards getting information into the hands of people. But what we were seeing is that information just didn't matter. It wasn't enough to move people to learn how to manage. So we had to go beyond simply having rote information, even highly tailored to an individual, and rather having information in the moment. Around the time that those thoughts were coming, the idea of personal health records as a device, as a tool that you could use for yourself, independent of your clinician, came forward. Technological changes, smartphones were beginning to appear, mobile platforms, laptops were being much lighter than the 25 pounds they had been originally. So there was a movement of technology, a movement of basically recognition of the healthcare system, that patients were important. And so when it got labeled personal health records, I remember thinking that it's the wrong model. It's not, the idea of a record isn't useful unless you can do something with it. So we started, even in our first conversations with the foundation, were about the need to think of personal health record systems, of suites of tools that people would use to take care of themselves. We did a lot of work on how do we create information tools to support this concept that care should not be looked on as from an acute framework, but rather as a continuum of care services. And we came to a process of understanding that the work had to be done in multiple places. You couldn't take one place and do it this one way, but we needed lots of different ideas. So we started with three basic tenets: actionability, separation of the data from the applications that use the data, excuse me, and high levels of user-centered, person-centered design. So the idea was we needed to move towards action. At the time, this predated a lot of the distributed computing that we have right now. But at the time, the idea of separating applications from data was an idea of being able to use lots of different approaches, lots of different data together, but not require that all the data be stored uniquely inside each application. So if I have a list of all the food I've eaten, I could have one program that tells me my caloric intake, but a whole other program that might forecast the amount of, did I have enough nutrients to run a race? We knew that we had to have multiple groups involved in it. We knew that we needed people who had experience in user-centered design or willingness to go with the user-centered design. And so in order to make the program work, we had to build in some supports for it. And two key supports were building in a design, it's basically a consultancy for the team, so that they could get really sophisticated help learning how to design these products. In the past, people would think of a design and they'd implement it right away. They didn't spend enough time in the beginning. We also had a technical group that developed the basic platform so that our teams could put all their efforts into the front-end user-centered design activity.